Well, thank you, Debbie, for that overly generous introduction, and I'd like to thank the HOPE Funds for Cancer Research for putting the spotlight on pancreatic cancer, something that's badly needed. Every 15 minutes, someone in the United States develops pancreatic cancer. This is devastating news because pancreatic cancer is looked upon by most as a hopeless disease. It's estimated that over the next year, close to 40,000 individuals in the United States will develop pancreatic cancer, and 38,000 will ultimately die of their disease. Only 2,000 patients, or 5%, will live beyond 5 years. Those 38,000 that die, most will die within a few months and with a very uncomfortable and painful course. Pancreatic cancer is the 4th leading cause of cancer death in the United States. Number 1 is lung, number 2 is colorectal, number 3 is breast, and number 4 is pancreas. But amongst these 4 cancers, pancreatic cancer has by far the worst prognosis. The 5-year survival for lung cancer is 20%, for colorectal cancer it's 65%, for breast cancer it approaches 90%, for pancreatic cancer, it's only 5%. Clearly, help is needed in the management of pancreatic cancer. That help comes in the form of funding for research. For cancer in the United States, that means from the government, principally from NIH. Lung cancer receives 3 times as much funding as pancreatic cancer. Colorectal cancer receives 4 times as much funding from NIH as pancreatic cancer. Breast cancer, 7 times as much. Even prostate cancer, the 5th leading cause of cancer death in the United States, with a 5-year survival that approaches 100%, receives 4 times as much funding. So clearly, we need the spotlight placed on this disease to increase the amount of funding. Now, why is funding so deficient in pancreatic cancer? There's no clear answer to that. But perhaps even the administrators and scientists at NIH think that pancreatic cancer is a hopeless disease and that funding more research probably won't be effective. But it's not entirely a hopeless disease. 10 years ago, the mortality for a Whipple procedure, the operation that's used for those patients who are potentially curable, carried a hospital mortality of 25%. That means 1 out of every 4 patients that had a Whipple operation died without leaving the hospital. Now in major centers around the country, it's 2% or even less. The pancreatic cancer genome has been sequenced at Hopkins. Imaging has improved so that if we can identify a patient who is at high risk of developing pancreatic cancer, imaging can demonstrate that cancer, can diagnose that cancer at an early stage. So some improvement has been made, but we are in bad need of 2 breakthroughs. Number 1 is a serum tumor marker that can be performed on everyone in this country age 50 or over to identify high-risk patients who can be imaged, say, every 6 months or every 12 months to pick the disease up in an earlier stage. Number 2, we need better adjuvant therapy so that patients following successful surgery have a better chance of long-term survival for taking care of microscopic residual disease that's left behind. We need better chemotherapy, we need better immunotherapy, and we need better radiotherapy. Those breakthroughs will come, I'm confident. It will be in the next 10 or 15 years. But with improved funding, I think they both could occur within the next 5 years. That's my hope. Debbie, again, thank you very much for that overly kind and overly generous introduction. I'd like to thank the Pardees for being such marvelous hosts, and I'd like to thank the HOPE Funds for Cancer Research for placing the spotlight on this disease so that hopefully we can receive increased funding. Thank you very much.